Today we will have a case discussion and we will have some fun together. First of all, we have this case. استلم القيادة. This is a female, young, يعني relatively young, 35, 36 years old, presented with upper abdominal pain. She is diabetic with chronic hypertriglyceridemia. Okay? خلي الماوس عندك اتوقع يوصل الواير مو صح؟ يعني you can take. So a CT scan was ordered for her and this is the CT scan and let's see what you have to comment. It's a matter of fact it's not a recent case, it's a little bit old, so I'm not quite sure what was the findings. We will try to see it together. So just scan and tell me what do you see and describe. Imagine you are in a exam or board exam or whatever. And tell me how would you perform. أهلا عليكم السلام ورحمة الله. Speak as you think. Tell us what you are thinking. So first of all, what is this exam? CT abdomen and pelvis. With or without contrast? This is without, but we have some with images. You can see it there. This is with or without. This is with contrast. Or oral or and IV or only oral or only IV? It's with IV contrast and mainly arterial to venous, somewhere in between.
Late arterial.
Okay, exactly, late arterial phase. Soft tissue window, axial images. First you have to start with these things. This is a CT scan of the abdomen and pelvis with IV contrast, the late arterial phase, soft tissue window, axial images, and now start showing. Speak louder. Diffuse enlargement of the pancreas.
With marked or extensive fast surroundings.
Okay.
And fluids also surrounding the pancreas.
So peripancreatic fat surrounding with the fluid and edema and whatever. Okay.
There's heterogeneous enhancement also pancreas, but there's no.
نياز أنا هنا والله ما دا أسمعك. صوت احكي أنت ما دا أسمعك. ترى هذا صوتك كلش عالي السبلت.
Heterogeneous enhancement.
Okay.
There's no any enhancement defect on pancreas يعني marked.
No enhancement defect in the pancreas. What do you mean no enhancement defect? يعني what does?
Sometimes there's ischemia or may related to the mass, clear mass, well-defined mass.
Not definite masses, let's say. And what is going on with this fluid or strangling? Where is it?
It's localized peripancreatic fluid.
Peripancreatic.
Extending to retroperitoneally.
Exactly. So show your colleagues retroperitoneally. This is the difference when you have pancreatic fluid or retroperitoneal fluid from the usual ascites.
Anterior
go down.
Renal area.
Exactly. Pre-renal.
Will be marked by the gyro.
Exactly. And if you go down, down, you can see the fluid is located where? Not in the center, on the sides. Okay? Go down, little pelvis, انزل, and you can see the fluid extending in the posterior part, even in the pelvis, go to the pelvis, you'll see the fluid where? In the cul-de-sac, retroperitoneally. Okay, this is not the ascites that we see like every day. Okay, indicating the pathology is mainly retroperitoneal. And what retroperitoneal structures we have? The main ones, let's say, we have the kidneys and the pancreas, the main ones. Of course, there are some there and here and there. So, let's see the, I don't know, coronal images. Down. No, you can just go this. It's exactly. So, let's see the coronal images and how do they look. So, we can see here what? The pancreas markedly enlarged, congested, stranded fat planes, surrounded by fluid extending in the retroperitoneum, and we can see a radial lobe. صح? So, overall, what is your differential diagnosis?
Acute pancreatitis.
Acute pancreatitis.
Autoimmune pancreatitis.
Autoimmune pancreatitis. Good.
Usually diffuse.
So,
and
what about pancreatic carcinoma?
pancreatic carcinoma. There's no any mass seen here or any dilatation of the duct or
Exactly.
and there's not any
What is the most common presentation of pancreatic carcinoma?
adenocarcinoma usually presented with mostly most of the cancer from the adenocarcinoma of the pancreas.
Present with what?
Hypovascular, well-defined
Clinically, not radiologically.
Obstruction of the
It's painless jaundice.
painless jaundice.
Painless jaundice
Of
is
the duct
pancreatic
wall.
carcinoma until
Wall
proven
by-
otherwise. Okay, clinically. Radiologically, you have CBD dilatation, intrahepatic biliary tree dilatation, gallbladder distension, in addition to pancreatic mass, so infiltration, metastasis, and all these things. So, the possibility of pancreatic carcinoma here, is it a possibility?
No, there's no dilatation.
No way.
No way.
It's impossible. Okay? Basically the only differential diagnosis is pancreatitis.
Inflammation.
Okay, inflammation. So the question here, why? Why does this patient develop pancreatitis? There is no biliary tree dilatation. There is no sign of CBD dilatation. No signs of CBD stones or pancreatic stone.
Heavy alcohol drinker.
No, she's a non-alcoholic.
But you mentioned about the lipid. The,
Exactly. And that's what, excellent. That's what I'm talking about. We are clinicians. We are not photographers. The clinical history is vital to us. The presentation or the history that I given was patient with abdominal pain secondary to, or she's having hypertriglyceridemia. So this is a pancreatitis secondary to hypertriglyceridemia, which can cause pancreatitis. Okay? دائما الclinical history is very, very important. Keep it in mind. You have the patient, go ask him. Don't wait for them to tell you. A lot of times, even the history they give is wrong. A lot of times we get patient with epigastric pain and it's not epigastric, it's right iliac fossa. It happens a lot. Okay? Good, thank you very much. So, let's see. And this is the native. What do we have? Whites. This is the localizer. Let's see. Do we have without? Most likely it is fatty infiltrate. أصلاً there is hepatomegaly secondary to fatty infiltration. Just let it load. Let's see. So this is the native images, and you can see the liver is fatty, of course, and it's enlarged. And you ask something about, yeah, there is an adrenal adenoma, or what we call it in this case, what? We call it incidentaloma. We discovered it incidentally. Okay? يلا. Who's next? من متطوع؟ يلا. Third, fourth, fifth, fine. حتى كيس قدر أهل العزم تأتي العزائم. زد 317. This one here. Can you see it? This rounded thing. Okay? Yeah. So 317. Let's see case number 317. So this is a brain MRI of a 28-year-old male patient presented with abnormal movements, and he's 28 years male. Okay, so these are the images. Do what you like. You know how to use the. This is the what's this sequence? شو اسمه هذا sequence؟ عمك راح يعطيش T1 this bad. This is scout, exactly. These are localizer images, scout, not real not diagnostic quality images. All of these are scout. And now we have the images. What do we have? What's this? T2 flare with fat sat. This is combined, flare and fat sat. This is a very, very nice sequence to demonstrate pathology. So remove the fat and the fluid. Okay? So we have T2 flare coronal with fat sat. باعي عالم الشغل. Speak as you حتى don't just look. لا لا مو speak pathology, speak. This is a T2 axial images of a brain MRI showing, for example, normal cortex, normal, إلى أن you find pathology. Don't just scroll and silent. It gets boring. Dilated ventricles, okay. Sorry? Good. 28. So, do you think, first, do we have any signs of inflammation, like cerebritis, for example, or abscess? Good. Do we have any signs of tumor? No space occupying lesions, no mass effect. Do we have any migrational anomalies? No. Do we have any signs of hydrocephalus? We have dilated ventricles, not hydrocephalus. There is a big difference. Patients with brain atrophy, they have dilated ventricles, they don't have hydrocephalus. Hydrocephalus is when you have dilated ventricle with effaced cortical sulci. If the cortical sulci are normal or prominent, like in this case, this is not hydrocephalus. This is just part of brain atrophic changes. So let's see this. ارجعي لي على الكورونا هذاك just a sec. Yeah, okay, this one. So what's apart from the dilated ventricle, what else can you see? And by the way, this is a difficult case. It's a difficult case, and it's not an easy one. Wait, your colleague is... What, describe the shape of the ventricle. Is it normal shape? Is it fused? Is it, I don't know, prominent on one side, not prominent on the other? Is it what? The frontal horns are more prominent than usual. Okay? And why is that? Let's go to the T1. Show me the T1 axial images. T1 axial. Leave the mouse. Wait. Look here. What's going on? Dilated frontal horns. Why? I know. What's going on with the basal ganglia? Atrophied basal ganglia. Okay? Show your colleagues. Where is the basal ganglia atrophy? ارجعي على ال T2. Yeah. Where is the atrophic basal ganglia? The lentiform and the head of caudate, it's very small. So, what's the name of this lateral ventricle appearance? Let's see here. This is very nice to demonstrate the basal ganglia. You can see here, they're basically just this one, okay? Just this one, okay? So this ventricle shape is called box-shaped, exactly. This is a box-shaped lateral ventricle. So, what's your diagnosis? And not differential, your diagnosis. This is Huntington disease. This is a typical case of Huntington disease. Keep it in mind. The box-shaped ventricle, the atrophic basal ganglia, lack of signs of hydrocephalus. The ventricle is dilated, however, the sulci are normal or even exaggerated. You don't have a dilated ventricle with hydrocephalus with normal sulci. I'm sorry.
بس البرين atrophy يعني.
Yeah, sure, there is atrophic changes. I'm saying atrophic changes.
يعني basal ganglia with cortex مثلا.
The cortical atrophy is useless. It will provide no diagnostic information for it. صح؟ مجرد there is like trillion cause for cortical atrophy. But this appearance of the ventricle with the basal ganglia is typical for Huntington disease. Keep this in mind. This box-shaped lateral ventricle is typical, especially when you have this amount of basal ganglia atrophy. Okay? Thank you very much. Excellent. Very nice. بدي ادور عليك وينك؟ Let's see. خلينا نلاقي لنا شيء يليق بالمقام. خير؟ Let's see 300 شهور الوقت زين عندنا وقت 308. So this is a 12-year-old male patient presented with disturbed level of consciousness, على شوية abnormal movement, على delayed milestones, يعني من هاي الشغلات. Okay? So brain MRI was ordered for him. What's this exam? This is scout or localizer or survey, whatever. كلها نفس الشيء. Again, and you can always look here. You can see what is the exam. This is that. And tell me, what do you see? Coronal flare with FATSAT. Ako flare without FATSAT or flare with FATSAT. In our center, we do flare with FATSAT, which is a very nice sequence. Showing. Okay, little bit increased periventricular signal on flare images. Let's see the XGLT2. What do you say? What do you think? We take, just wait a second. Yeah, good. Yeah. Take the XGLT2. Let's have a quick look on what's going on. Is this a box-shaped ventricle?
Yeah.
Huh? يعني ما معقول اثنين هانتينجتون واحد ورا الثاني. It's too much يعني مو لهالدرجة. So lentiform nucleus is showing a high T2 signal intensity. You have to be specific. What else?
Posterior pons.
Posterior part of the pons is also high T2 signal intensity.
Midbrain.
Midbrain, exactly. Go to the T.
Dentate nucleus.
Where's the dentate? What's wrong with the dentate?
Normal, no high signal intensity.
So, go to the T1. Let's see the appearance on T1. What does it look like? These areas of increased signal intensity.
Hypo on T1.
They appear a little bit hypo on T1. Okay? اعطيني الماوس ما يخالف ثانية. Just let me demonstrate something for you. So on this,
Nice central part of midbrain show high signal intensity, spheric periphery.
what is the name of this sign? يلا. Huh? This appearance here. شو يشبه هذا؟ Okay, بعد. You are يعني not so far away. Do you have any idea what's the diagnosis?
Ray disease.
No. Of course, it's within the differential, but Lay's disease, it's basically calcifications, right? As you know,
لا
right?
فهمنا.
ذاك الفرق. Oh, sorry, I'm sorry, my mistake. So, what else? أحد يعرف شنو هاي الساين؟ لا ذاك الام اس اي multiple systemic atrophy ذاك بالاولد ايج هذا 12 years old child sorry intensity okay so then what does that mean encephalitis do you agree on encephalitis
No.
good she doesn't think لا keep it simple
And history of مثلا electrolyte disturbance.
No.
Contained my
long standing process for several years. Some of the family members have the same
mitochondrial anterior posterior.
just wait so this is Wilson disease. Okay, this is Wilson disease. What's the sign? Panda sign. Exactly. This is a typical panda sign. What about this sign? This is mini panda sign. So I have panda sign and mini. هي وابنها. الباندا الكبيرة وابنها الصغير. This is the mini panda and this is the Mama panda. Okay? So this is also a case of Wilson disease. If you have this case, what would you recommend? Or what would you do? اجاك للكلينيك or the center or the hospital or whatever باش ديوان شو راح يشتري لك؟ ما نعرف بعد هذا يا ماما. زين؟ وجاك هذا الكيس شو تقولي له؟ First of all, what you do? Ophthalmology exam. Looking for Kaiser Flusher ring. Kaiser Flusher ring. اللي هي حلقة تصير around the cornea. Sorry, iris. Iris. هاي مصابة ophthalmology. First, second, what would you do?
liver يعني
Abdomen ultrasound. Looking for liver. Looking for what? شو تدور بالليفر؟ tumor.
كبر deposition.
شلون نشوف الكبر deposition بالultrasound؟
يعني echogenicity.
Echogenicity, you look for what? You look for signs of liver cirrhosis. Secondary to copper deposition, we don't see the copper. And you send for serum copper. And the most important thing is what? You send the whole family for screening. It is hereditary and it's treatable. Okay? كل الفاميلي تروح screening. Okay? Excellent. Good job. هلا تعال يا القاعد ورا وتحكي بالباندا والويلسون. تفضل راوينا عضلاتك. خلي نشوف انت يراد لك فشي ما نازل بكتاب لازم هيك يعني. خلي نشوف ايش عندي والله
ما اجي بس
تسعة وثمانين سهلة تفضل هذا الماوس and ني اسهل من الني بعد شو اجيب زين ني MRI of a 40 years old male patient post trauma this is sagittal this is proton density fat sat اللي هو احنا نسميه تيتو يعني شلون نقول الدارج بس هو مو تيتو هو proton density fat saturated image sagittal showing
first we have the ACL there's high signal within the ACL
good
and thickening
good
with the disturbing of the fibers
يعني ACL rupture or not
the alignment is okay
mm-hmm.
yes it's maybe partial rupture
Exactly, like sprain or partial tear or whatever. But it's not completely ruptured, so he does not need an ACL reconstruction surgery. High first, bad. Sorry?
Mucoid degeneration.
Yeah, it can be, of course. And if there is no history of traumatic event and in an older age group, this is 40, not old. شو تقولين 40 old لو young؟ مو؟ ازعل بعدين. زين.
PCL buckling.
لا it's good come on this is a normal PCL. زين. روحي لنا للكورونا خلينا نشوف شكو بالكورونا.
هذا الباتلا فيوجن فلويد يعني.
اوكي.
Maybe bursitis
Bursitis or whatever. What else? What's this sequence? T1. Without fat sat, just T1. And here we have
coronal also proton density.
exactly. زين. What's the main abnormality here? شنو الشيء اللي يجي بوجهك اول ما تفتح؟
Joint space, loss of joint space.
Really?
تقريبا.
Okay. تيك ات ايزي، لا تباعي مو فد شغله يعني هيجي فلكيه. عادي بيشنت اجى للكلينيك عنده تروما ويريدوا له ام ار اي بس، لا اكثر ولا اقل يعني. ما راح يطلع فد شيء عملاق. What's the main thing that catches your eye من تشوفين الصوره؟ Come on, this is a normal joint space. من نسكاس حلو يخبط كل شيء. وهذا قلت واحد عمره 70 سنه، هذا يوم 40 اصغر مني. يعني قريب مو؟ عافيه عافيه 5 درجات. زين. First of all, no one line we don't say this. We say intensity. هاي أول. صار يشتغل intensity مالته. It's normal. Good. Let's go to the axial. Maybe it will help us even more. What do you see? Tell me. زين هذا كله ما did not catch your eye. edema or fluid. فرق edema and fluid.
localized fluid.
When I get someone punch me, I'll have edema. But this is a fluid, subcutaneous.
This is subcutaneous edema. This is TRE.
Exactly.
This is localized fluid.
It's a fluid. بالاكزيال what's the distribution of this fluid? شوفي لنا axial. Okay. It's almost circumferential. Okay. Separating the skin and subcutaneous tissues from the joint.
هذا البوست تروما أكو شيء يسموه.
اي شو يسموه؟ اي تنجرد. شو يسموه؟
هو مثل هيماتوما تصير. لا.
شنو؟ سلافي؟
ما أعرف شيء فالاسم كلش صعب.
اكو الاسم هو الصحيح بس اكو اسم اسهل له.
إديما هيماتوما تصير مثل.
اي. The skin and the subcutaneous tissues is pulled from the joint. يعني if this is the skin, it's pulled from the joint. ينصلخ. يسموها degloving injury. glove deglove. واحد نزع الجلوف الكف اللي يلبسوه بالشتاء. احنا ما عندنا شتاء بس بيشوفوه بس يعني الفكرة واحدة نفسها. you can say degloving injury. الاسم اللي هو المال اللي اكتشفه اللي هو ولا عمركم يعني اذا تحفظوا منها 3 دقائق راح تنساه. اسمه موريل لافالي. موريل لافالي انجري. ما راح تقدر تحفظها حقا. It's degloving. glove deglove. Okay, exactly. It happens. طبعا in the knee it's يعني you see it every now and then. degloving ينشلع اللحم من العظم.
يعني هذا السكين مو موجود عندنا.
ها السكين انتاكت بس separated from the joint.
يعني طبقتين جوا.
اي موجود الانجري جوا. اوكي it's degloving injury or Morel Lavalley injury. اوكي زين السينيورية خلصوا ولا بعد؟ السينيور ريزيدنتس منو ظل؟ اكو واحد نزل عينه من جوا هيك ماكو لسه مع سينيورية. زين يلا let's one more case and we will stop here now. let's see دقيقة اصبر خلينا نلاقي لك شيء
بسيط.
اي بالضبط.
يعني دوب الوقت.
اي على مود الوقت انت عارفه. زين it's an easy one. 78
مرات ايزي مرات ما تخرب.
والله احتاريت وياكم اجيب صعب زين.
هو موضوع الدسكشن يعني.
احنا we are having fun. هذه الايديا. This is a 33 years old female patient. She has an abnormal ultrasound, pelvic ultrasound with some vaginal bleeding. Presented for an MRI. So, احكي لي يعني من دا تشوفين احكي what's this sequence this is a collizer or survey or scout whatever what's this sequence T2 sagittal T2 with or without fat sat with or without contrast
without contrast.
I will fail you right now
لا دقيقة.
ها
تيجو ما يجي contrast.
بالضبط
إيه.
don't fall for trick questions it's a T2 ما
تيجو
contrast
contrast. إيه.
so لا تقولي without contrast it's a T2
إيه يعني
لا وقت 20 حكي يعني T2 you don't use it. حتى لو contrast nothing will happen ما حيصير
كورونا.
هو لازم كذا هاي التريكس So.
كورونا بتيجو.
عم يجلد بالتحكي هو احنا عامله غير السينيور مالتنا شو يصير لا مو لا هاي sagittal T2 fat sat with or without contrast good thick endometrium okay what else 33
الجنكشنال زون وايدن.
maybe
هي bulk uterus.
bulky uterus زين
ovaries هاي.
شوفي لنا هذا الاكسيال والله نشوفه زين showing what let's see اصعدي خلينا نشوف بعد so the endometrium is what
cystic changes.
micro cystic
changes.
endometrium or endometrial cavity let's say
material cavity.
Okay.
cystic changes.
Mhm.
هو طبعا
the junctional zone looks relatively intact so do we have any free fluid in the pelvis
no. mild.
there is some okay the ovaries they look
right ovaries.
mm,
District ovary here.
yeah good yes then let's see the T1 see what's the difference here what do we have here these the endometrium showing what
high signal.
few foci of
high signal hemorrhagic ممكن.
T1 hyper intensity which indicates blood صح أو micro hemorrhagic foci good what do you do in this case هاي كيس جتش لا اصبري انت شو تسوي
التراساوند.
هي جايبه بنورمال التراساوند
هي
اصلا
جايبه ابنورمال التراساوند. نسوي لها يعني هو بيوتي تيست حتى اذا ممكن مولر
دقيقه زين ما تعطيها كونتراست
كونتراست.
البيشنت بالجهاز تعطيها كونتراست ولا لا
هي اعطيها. ايش قد عمرها؟
33
33 يعني اوكي.
نعطيها كونتراست ولا لا
لا لا.
ما تعطين كونتراست
ما أعطي.
ليش ما تعطين كونتراست
ممكن تكون pregnant.
ممكن تكون الام ار اي ما شفتي البريجنسي الكونتراست راح
يعني هذا الثيكنس خلي نسوي لها يعني بلاد تيست.
زين سويتي لها بلاد تيست طلع بوزيتيف تعطين كونتراست ولا لا
يعني هو عندي ديفرنشال يعني
راح يجيك التكنيشن يقول لك دكتوره اعطي كونتراست او طلعها من الجهاز
طلعها من الجهاز.
طلعها من
ما
الجهاز
أعطيها كونتراست.
ليش ما تعطيها وين الجستيشنال ساك
هو بس احتمال يعني بعدها يعني بالبدايه يعني بس هو ممكن مولر
الاندومتريوم هالثخمه كلها هيموراجيك فوساي يا بدايه
يعني
لازم تعطيه
لازم
كونتراست
أعطيها.
طبعا
اذا بريجننت يعني ممكن ايرلي بريجننت.
البريجنسي ايش قد يعني early
لا هو
pregnancy؟
الساك ما مبين بس ممكن اقول مثلا اعطيها
شوفي هنا البوست كونتراست هذا شنو هذا بري يمكن اي شو انزل يقول شو بعد اي تمام هاي شوفي لنا جود This is T2 fat sac post contrast
لا مو جي. T1.
صحتي عافيه زين. So T1 post contrast showing.
هاي المنطقة
شوفي ان هذا الساجيتال شو يطلع بيه. So is it enhancing, non-enhancing, what? نزلي لنا هذا. نزلي لنا شوف السيكونسات بعد. شوفي هذا. Yeah. So this is coronal T1 post contrast showing. ايش قد الدوز مال الكونتراست باليوم هذا؟ ها؟ دادرينوم حبي ايش قد تعطي؟ فكر انت ليش؟ ايش قد الدوز مال الكونتراست؟
ما حافظة مال كان الكونتراست العادي 1 بير كي جي يعني
1 سي سي بير كي جي بالسيتي سكان.
ايه
بالام ار اي it's 0.1 to 0.2 مليمول بير كي جي. ايش قد المل بي؟ كم مليمول بالمليلتر الواحد؟ لازم تحسبه. نبي نسميه ذاك السيتي سكان. السيتي سكان تحنا 70 ملي جرام بير مليلتر. بالام ار اي we are talking about 0.5 مليمول بير مليلتر. المليلتر الواحد ب 0.5 يعني كل 5 كيلوات تعطي سي سي. اوكي الى 2 سي سي 0.1 to 0.2 مليمول بير.
لا تقارن بس ناسيها كلها والله.
ما كنا نسينا براكتس ايش قد تعطي دوز زيد لي قلل لي صح؟ يلا. So showing diffuse enhancement of a multicystic multi-microcystic lesion within the endometrium. انزلي اللي جوا منه انزلي ايش بقى عندنا؟ شوفي ان هذا without fat sat زين. So with a positive pregnancy test, this is a case of an H molar pregnancy. Okay. السؤال اللي يطرح نفسه ليش هذا T1 صح؟ زين. بعد ليش البلادر هايبر انتنس؟ لا T1.
لا دقيقة T1 بوست كونتراست.
نسوي ديلي ايمج بالسيتي شوف البلادر
كونتراست بديلي.
صح؟ كونتراست طلع عند الكدني ونزل. بس شوف البلادر شنو؟ هايبر انتنس. هو مو T1 بس بوست كونتراست. طبعا لازم نقول انفيزيف ولا لا ولذلك اكدنا انه جنكشنال زون اوكي so this will they will do a DNC okay and they should do chest abdomen or we should do chest abdomen pelvis CT to look for possible metastatic lesions اذا انفيزيف حتى اذا لازم انفيزيف at least you مش مدري شنو metastatic okay and she should take a course of methotrexate just to be on the safe side.
زين يعني هي مسوي التراساوند اكيد الدكتوره راح تدزها بي تي. ليش تدزها ام ار اي قبل البي تي مثلا؟
منو قال؟ لا هي جايه وياها كذا.
ليش تدزها ام ار اي؟
يشوفون انفيزيف ولا لا؟
على مود بس
انفيزيف ولا لا؟
إذا انفيزيف الجهاز يختار بالفاتسات.
اذا انفيزيف ممكن هيستركتومي يسوي. Here we have to see carefully and look for the junctional zones. Any sign of invasion, we should report it. I'm interested about the diagnosis rather than whether it's invasion or not. Well, I usually use it. For me, I use it. Was the benefit of contrast to see if there is any sort of hidden invasion, let's say. يعني مرات تشوفين الكونتراست أول شيء I'm not sure I was not sure about the pregnancy test when she came first. Second, she says I don't think I am pregnant, but she is pregnant. After we demanded the pregnancy test, till we knew that it was positive. After the MRI, we did the pregnancy test.
For example, if it was invasive, so
see the lesion in the myometrium going through the junctional zone. شو والله شو بتشوفي هذا؟ If you اعطيني والله الماوس. If you look carefully, you do a hard window, okay, and try to look for any signs. In fact, I think there are some foci, maybe possible foci of invasion here and there, okay? So they should do a DNC and be sure that
يعني هي
it is a partial mole or complete mole, okay? يعني see this junctional zone is not really like very well defined, خصوصا at this area. We will, okay, and we will try to, while here it looks intact, okay, the junctional zone.
يعني معناته دكتور يعني هاي بصراحه احسن من الكونتراست هاي السيكونس
ممكن طبعا
يعني
ممكن
مرات ما نحتاج كونتراست
بس
اذا
انت ما عندك فيتس.
ايه حتى
You give contrast no matter what. We are the only contraindication in this case if there is a fetus. Well, we have no fetus. So why don't?
يعني اذا بالايرلي ممكن اكو اندكريز بعدين
If I'm suspected early pregnancy, no, I will stop.
pregnancy فممكن اكو يعني postponed باسبوع مثلا
ممكن.
حتى شو اذا ما كسر حتى انطي
It's teratogenic, yes.
first trimester
Gadolinium is teratogenic. إذا لازم تنطي contrast, if you have to, you should inform the mother, the father, and the gynecologist, and all of them sign. I am informed, I agree. I am informed, I agree. حتى الجاينكولوجيست الريفيرال يوقع. مو بس الأمهات. حتى لا يروح له وذاك يرجع يقول له شو كونتراست وقعي. قبل لا أعطي كونتراست.
إذا junctional zone breach يعني كان يكون كارسينوما سيرفيشال كارسينوما
Choriocarcinoma is a possible,
as a differential
but you need a pregnancy, a real pregnancy. You need a placenta there. تمام? I really don't have the pathology, histopathology, unfortunately, of the case. If I have it, I would tell you what's.
طيب دكتور
In both cases, she will go for DNC. ممكن يصير طبعا.
بس دكتور ليش هذا التأثير؟
ليش دازين MRI؟ أول شيء ما كانوا مسوين كيتي. pregnancy test. ثاني شيء الالترا ساوند كان thick endometrium, multicystic malleation. They did not
لا
know.
إذا مسوين بي تي خلاص رأسهم يروحوا
بحيث انه بيشنت دزينها تسوي بي تي وفوتي الامراض بينما خاصيه ولا يطلع
بس البيتا اس سي جي
والبيتا اتش سي بعدين دزينها وكان انفيتد.
والله يحتاج احنا نتعلم شو نطلع اليوم
مو زين
ما طلع عليك
مو زين نسوي حرام عليك. Yes. Suspicion. It could be suspected invasion. يعني possible. They have to take it in consideration. إيه. In MRI, there in post-contrast images show possible invasion. So they have to give methotrexate, a course, and then follow up another MRI to see if there is any residual disease, if it's increasing, if it's metastatic, or everything is stable. Follow up, yes, you have the. Tamam? Thank you all. Very nice discussion.